And the next segment is going to be on AI in production. And to lead this session, may I please invite our moderator, Dr. Shashikant Pawar, the Chief Operating Officer of Kokilaben, Dhirubhai, Ambani Hospital. Let's have a huge round of applause for Dr. Shashikant Pawar. I'd now like to invite our speakers for this session. This entire session is going to be AI that justifies the investment. And I'm clearly in agreement with the statement. I'd firstly like to invite our speaker, Mr. Saurabh Gupta, the Regional Director of 𝗃𝘃𝘀 Hospitals. A huge round of applause. I have visited 𝗃𝘃𝘀 and I am totally in agreement with the class of service that 𝗃𝘃𝘀 is offering. Well done. And now I'd like to invite our next speaker, Mr. Neeraj Lal, Regional Director, Maharashtra and Karnataka Region, Medicover Hospitals. A huge round of applause as we welcome Mr. Neeraj. And now I'd like to invite Dr. 𝗃𝘃𝘀𝘁𝗵, the Managing Director, Lilavati Hospital and Research Center, Mumbai. Let's have a huge round of applause as we welcome Dr. 𝗃𝘃𝘀𝘁𝗵. And now I'd like to invite Dr. 𝗃𝘃𝘀𝘁𝗵𝘁 Let's have a huge round of applause for Dr. 𝗃𝘃𝘃𝘁 from, she's a Group Chief Operating Officer from the Apex Group of Hospitals. Let's have a huge round of applause if she's available. And last but not the least, may I please invite Mr. Anoop Arora, the founder and CEO of itDose Infosystems Private Limited. Let's have a huge round of applause as we welcome our speakers for the AI in production segment. And over to our moderator, Dr. Shashikant, to take over and lead the entire discussion.
A very warm welcome and good afternoon to one and all present over here, my colleagues, my distinguished administrators, CEOs, and the panelists here. She has already introduced all the panelists over here, so I'll just try to open and understand what is the topic we are going to have today. Is mainly we talk about the AI. I think since the morning we have been talking about, we are understanding what is AI. It's not only the chat GPT, is going beyond that now. It's in your Meta AI, maybe in your WhatsApp, maybe in your Google AI, everywhere now it's been said, right? The chatbots and all, whenever you want to buy something on online also, the chatbots are there available. So healthcare is not something which is out of it. We are also having initiative that has come up. It's no longer as an AI initiative nowadays. So when we talk about AI, we say how is going to implement it, how are we going to take it forward. But it's not only about what it will do now. That's what is the AI going to do now. The question now has shifted out, is it going to deliver financially? This is what the management or the governing council, the board of directors are going to ask the questions to the executives who is going to put up the questions to them, that this is what the technology, this is what I'm going to bring in. So when we talk about clinical things, a lot of things have been implemented already. Maybe in the healthcare, mainly known to us in radio diagnosis, how the TAT can be reduced, how the early diagnosis can be done, how the real-time integration can help, how the remote level things can be managed. So all these things are already in place. We are able to know what are the predictive analytics happening. We know with some devices which will help us to know which are the patients with the clinical conditions needs to be prioritized for the care, and what forecast of the treatment we should do for that, and how the sickest patient can we take care so that he goes home from the hospital and the mortality can be reduced. That is what we look at, the patient outcomes, right? And I'm sure a lot of people over here sitting will agree on to it. So AI is not something for me which comes up is an augmented intelligence, not as an artificial only, because human intelligence integrated with an artificial intelligence will give us an augmentation, and that is where it will become a promoter or enable us to deliver the better services in a healthcare to the hospital. And that is the concept which I go with. And this is what we believe in our hospital also, to conceptualize it further. So we'll try to go ahead with this. We will talk maybe possibly more of budgeting things and how it is going on with the leaders sitting in on the panel, to understand from them what we'll do that. Because without knowing the financial risk of AI in a structured manner, again a fiasco can happen tomorrow. So because anybody is going to ask you what is the return when I'm going to invest so much into it. So could be financial returns, the benefits what we call, could be tangible financial benefits or non-tangible financial benefits, over the cost which I'm going to invest. This is what will be the bottom line of our discussions today. Thank you. So we have on the left with me Mr. Saurabh, Regional Director, KIMS Hospital. So I'll start with him with the round one, and I'll request all the panelists, let us stick to the timeline so that we'll try to schedule it as within the time frame which we have been assigned to. So we start with the first question with Mr. Saurabh Gupta. So when somebody gives an AI proposal internally, within the group of hospitals and the business case study, we generally look forward like, I need to present it to the person. Now, who's the person whom you need to convince first in the room of that boardroom so that it gets passed?
Thank you. Very interesting question, in fact. So I'll give you a very practical scenario. So I was actually talking to my CIO and CFO couple of months back. And one very interesting analogy what my CFO told, in fact, it was pleasure to my ears, music to my ears to hear it from a CFO. He said, you should not put anything as a tech proposal or a AI proposal. You should put any proposal as a problem solving proposal. AI is one of the tools and it is getting integrated. But what is the problem you are trying to solve? It is not an AI proposal. So that is a paradigm shift which we are trying to get. What is the problem you are trying to solve? AI is one of the elements, which it could be another things, multiple scenarios can be there in that. So that is one thing which now we are trying to do. We are always defining what is the problem we are trying to solve through AI or another means. So that is the one thing which we are changing, and that really helps, because if you start talking about only digital or AI, then sometimes people in the boardroom, their attention span is not so much. So they are more interested in numbers, which of course you have investors' money, they have to be. But yes, they would be interested to know, are you trying to reduce the cycle times? Are you trying to improve efficiency? Are you trying to diagnose more efficiently? Are you trying to increase the accuracy of the diagnosis? Yes. That is the problem you're trying to solve through AI. Now, here is where AI comes. So there are three things generally which any board or an investor looks into. One is, of course, what is the problem statement? You are trying to increase the clinical throughput, or you are trying to reduce cycle times. Revenue cycle today is a big thing in which AI is coming up in a big way. Then screening of resumes, CVs in HR, not many hospitals are using. So these are some of the things which they would be interesting to know what would be the throughput and by what percentage it would be reduced. The second thing is clear-cut ROI. So I can actually correlate the current AI proposal or AI infancy to what we had in digital almost 8-10 years back, when everybody was questioning digital, whether we should put money in social media or we should not. Now there is a clear-cut clear-cut ROI. So you have 1:4 generally ratio, and it varies, but for every $1 spent, you get around $4 if it's done properly. Even globally, and in India, such benchmarks are not available to my best knowledge. But globally, around 3.5 for every $1 spent, 3.5 to $5 is the payback to invest in any AI solution. And the third and the most important, so it would be interesting if you can actually project what type of ROI you forecast if you go on to any of the proposals powered by AI. The third and most important is, what is the scalability of the proposal and what is the acceptability? Because what happens is that you ask me this question, who is the difficult customer? So if, stakeholder and customer. So my third point actually answers that also. Majority of us, and I also used to think before I actually went to discuss some of the things, is the CFO, it's the finance guys. Of course, they will ask for ROI, but that's not the case. They will ask questions about ROI, but the most important customer or the stakeholder in any technology or AI solution which you are putting is the front level operator. Because if the front level operator is not convinced about how it will ease his life, the entire solution will fail. And that is what I have seen. So it is very important for us to tell them what is in it for them, how their life will be easy and how their jobs will be safeguarded. Otherwise, it will not be a success. So, scalability, acceptability, and convincing the frontline operators, I think that remains the paramount. Thank you.
Thank you, Saurabh. And that was quite a little explicit onto it to understand that we need to see the internal stakeholders and mainly the finance guys, as he said, to the point to the question. Moving ahead with Mr. Neeraj Lal, who is the regional director for Maharashtra and Karnataka at Medicover hospitals. So when we talk about any proposal coming in, from the vendor and they tell this is the tech and this is the AI tech, what you have to implement. There is an implementation process. Then we ask the questions, how much time it will take for me to get a return of investment? Well, let me take you back a few years back when this AI has just started. Before that, we had the equipments coming in, right? The heavy duty equipments. When we put here, we always ask our stakeholders, what is the return of investment we are looking at? Generally, we keep it at the 5 years timeline for that, so that at least we get something in back. Here, maybe in the tech, we look at something around 12 to 18 months. What is the timeline we are looking at? But after the implementation of that project or that kind of a tech over here in the hospital or maybe any healthcare sector part, sometimes that timeline is not met rather, I can say, the post deployment. And like, sir, I would like to know from you, how do you like to manage your vendor with your leadership in such kind of scenarios? They are not able to meet the timelines or neither able to show up after the post deployment. The promises what has been made, I'll give you this, I'll get that, after that आपका streamline हो जाएगा, everything will get in sorted, you'll get the throughput of the patients, your volumes will increase, and that is always the attractive part. Your patient volumes will increase, your business increases, but it doesn't happen.
You're very right. Management of vendors. I'll talk about something about practical parts. See, vendors, if you don't co-own them, vendor has to co-own the ROI. ROI will not only come from the hospital side. Three people, I think, plays a very, very important role in healthcare. One is the most important player, doctors. Because we don't buy AI, we buy outcomes, number one. Secondly, if we are taking a AI solution from a vendor, so please co-own him. Because if you're not co-owning him, maybe you can spread out the payment, partial payments. Once you reach this, then you will get that. Third, your own staff who is working around this AI ecosystem. Sometime data is not flowing properly. Sometime workflow is not very proper. So I think if we integrate these three things, this AI will work very, very genuinely and very, very good. I was talking to Saurabh during lunch. We are seeing so many vendors these days, startups and all. By the time you talk to some vendor, and by the time your AI is implemented, he or she must have left that company also, because it is most people driven also. So I'll give you example. Say for example, we started some AI based project in the hospital. So we are telling to the doctors and we are asking the vendors, by taking the solution, there should be a reduction in TAT. There should be a reduction, there should be OP to IP conversion. Like your ultrasound, the waiting time for ultrasound or is, say for example, 25 minutes, it will get down to 17 minutes. If you talk these statistics to doctors, I think it will make a difference. I'll give you example of Apollo Hospital when I was there in Gujarat region. So there was a project which we have taken, like we were having around 75 ICU beds, but we were managing around 2,400 ICU beds because we are having a virtual ICU solution with all the nursing home close by to that hospitals. So we have taken an AI vendor and we have installed this on the request of government of Gujarat. So it will not happen on day one. As we were talking, it will take time. First 3 months will be total confusion. Next 6 months, there will be stabilization phase. And after 1 year, you will start getting ROI. I think we have to understand that thing from day one, whether you are working with a promoter, whether you are working with board or anyone. I think these are the 3-4 stages we have to maintain, and then you will get the ROI.
Very well said, sir. I think you have concisely put it very clear onto it that co-ownership with the vendor is certainly the way forward into looking into it. As he also mentioned about the clinicians or the doctors needs to be partnered into it. So we move ahead further with Lieutenant Colonel Dr. L.C. Verma, Medical Director at Lilavati Hospital, on the right side of mine, and like to take a question onto it with him, just to understand, like, we always try to involve the clinicians also beforehand and tell them that this is what the ROI going to be for the AI technology or any other tech which I would want to implement into the hospital or deploy it to it. Then how the clinical teams in the ROI conversation, we would like to involve them so that they become the stakeholder and make the change in the outcome. As he said, Mr. Neeraj Lal has said, the doctors, once they become the partner and they are understanding that you are looking for an ROI from this kind of a technology, increasing the throughput. I think we just got a demo today with some, sir has given, the doctor and a patient interaction directly uploading into the system. So that throughput of the patients can be increased. A doctor who has a busy OPD can see more patients in his OPD, like maybe 10 patients more, because he is not involved into documentation. That can be augmented, that can be fastened up further. So that being an example to it, like the ROI conversation, once you involve them early, you can see 10 more patients, then actually does it change the outcome?
At the outset, let me thank the team DHN for arranging such a beautiful dialogue. Thanks, Dr. Shashi, for this question. You asked about involving the clinicians when we think about adopting an AI tool. So here, three things. The most important thing, you have to decode the problem statement. What mistake we are making, we involve the doctors or the clinicians who are the end users in the last. So that is the thing which will affect their morale, affect their energy, and they always feel that this is the management call. You also talked about ROI in terms of financial figures or operational figures. We don't speak about the clinical outcomes, the PROMs, the patient-related outcome measures, the clinical events. Let's say the length of stay going down, out-of-pocket expenditure going down, SSIs, those are surgical site infections rates coming down, hand hygiene rate being boosted. So these are the clinical outcomes. If we involve doctors right from the beginning, they become the process owner, they become something like they would like to. Somebody had said that be the change if you wish to, what you wish to be. So if you want to involve doctors right from the beginning, I think they can take it forward. So the core values, the clinical values have to be identified along with the problem statement. There is also a mismatch, the demand and supply. I feel that the engineers and the people who are investing or inventing these AI tools, they are not speaking or they're not going to the hospitals and the clinicians to know the real problem. So this marriage has to happen between the clinical team and the inventing team to know the real problem, and based on this real problem, I think we can decide what is the demand. It should not be seen as the thrust upon, it should not be seen the forced approach by the management or by the third party who is investing. The topic is the AI that justifies the investment. The justification should come from the clinicians. They really want it. Yesterday only we were doing one demo of robotics-led sterilization. Because we felt that the team which is entrusted with this responsibility of cleaning and all this hygiene and sanitation, they are not doing up to the mark. So now we need someone who can be unbiased and who can give us the objective assessment of the problem. So here we brought this demonstration. And the other things, if you involve clinicians right from the beginning, I think they will own it, they will not resist the change, rather they will grace the change, and then only you can justify the investment in the AI.
Thank you, sir. Thank you for your answer. Quietly concise. Just taking ahead on to the point what is trying to make understand is let us play down certain metrics or the objectives defined before when we implement so that the ROIs can be measured. Example, I would like to put forward like a readmissions. So I want to reduce my readmission rate. So we need to first objectively define like from 18%, for example, if I have a readmission rate, is that tool going to help me with the outcomes, and my readmission rate will go by say 2%, 3%, 5% over a period of certain given timeline. And that gives me a clarity about my ROI in terms of tangible and intangible financial benefits as well. Or I say the turnaround time or the TAT of the lab diagnosis when I'm going to next question to you, that's why I'm talking about lab. So then can I reduce the timelines, integration, the real time, and the reports can be delivered to the doctor or the patient before time. So like if I am delaying my reports, like 20% of the reports are getting delayed, can I make it to 10% in next 6 months of implementation? So that measurable objective, once you define it, possibly is definitely going to help you out with the outcomes and involving the clinicians so that they will be happy and become the partners also to implement it in your hospital. So going forward with Mr. Anoop Arora, founder and the CEO of the itDose Infosystems Private Limited, I'd like to take a next question with him since he's from the diagnostic background. And the question goes with this, that, we have a lot of, integrations. We have the HMIs in our hospitals, right? Previously, there were no HMIs, no computers, manually things were going on. Then came the computers, just the computers. Then it came that you need to have an HIS or HMIS in the hospital. Your billing processes went on to it. Along with that, there is an integration we came with LIS, that is the lab integration systems, right? Then for radiology separately. So all this basically will be driven based on the data input what we have to put into it. The AI tool or the augmentation through happening with an AI, maybe any kind of an software you want to put with an AI, will work only when there is a data enough for them to analyze or to give the output on that, right? So, but looking at the infrastructure presently in India, do you really feel that we are ready with the data level when I want to implement an AI or in any diagnostic centers? So is that going to be an impediment, and how do you look forward towards it?
It's a very valid question, but before I answer this, because since morning I am hearing AI, and not this session, probably wherever you go for any of the conferences, now the topic is AI. So to answer this, I really need to give you an insight uh, in a very layman language. What is AI? I think AI is working on a concept of learning, then analyzing, and then predicting. So AI algorithms run on the data, they learn from the data, then they analyze and then they predict. And when we talk about AI readiness, so I would say AI readiness is just a combination of data readiness plus the process readiness and the governance readiness. You can have any algorithm, you write any algorithm, you can have any solutions, AI enabled solution, you can have AI enabled uh, HIS, LIS, wherever you name. But the major point is data. So when we talk about data, there are three major components which we believe that should not be ignored. If we ignore these three components, I would say we will get an AI solution, but these AI solution must give you the quick response, but all responses are compromised. And the three pillars for this data is, first and the foremost is standardization. We are serving more than 1700 plus clients across India, from the chain of hospitals, chain of diagnostic centers, to the tier 3, tier 2 city, 50 bedded single doctor owned hospital also, even clinics also, single lab who only have 50 samples in a day, and my clients are from maybe around 50,000 samples or maybe a lakh samples in a day. What we have found that there is a big gap of standardization in data in Indian scenario. I'm not talking about inter companies, means X hospital versus Y. Even in a same organization, having multi-center, multi-location, there is no standardization in data. We usually ignore master creations. We don't follow uh, the standard of your units, your methods, your things. Yes, there are a lot of good chains, and those are started using all those things. But you cannot make a decision based on 1 or 2% of industry. So the first and the foremost thing, if we really want to get the return on investment of on this AI tools, we have to ensure that whatever the data we are using before input, I'm telling you, whatever the data we are using, it should be standardized. We have to use ICD, line codes, CPT. There are a lot of things, other things also. Even if you are not using that also, at least you should ensure that your particular organization has unique codes at least. Second important aspect is structuring of data. Still you find many systems running across the healthcare providers, service provider, organizations. Everywhere we have a lot of spaces where we need to write free text in terms of your procedures, in terms of your notes, nursing notes. We have to be formulate and standardize these free text input also, because otherwise we will not get the best clinical output out of this AI tools. And the last, which is more important, is compliances. We right now, compliances are more important in terms of applications. The government is also putting a lot of efforts and making NABH approved or certified, ABDM coming up into this segment. And there are a lot of things. Until we have these things with us, we will not get the actual output of AI tool, whatever it is.
Yeah, thanks, sir. We are running short of time, so maybe I'll request the panelists, the next round of questions, maybe you can answer within 1 minute or so. So we'll try to fix it up at the earliest possible. So Dr. Saurabh sir, I would like to know, when does it happen that, the AI project budget line becomes a core operating cost, it overboards it, and at what has pushed you that threshold for you?
So I think this is a futuristic question, because we are yet to see, the AI cost or the AI budgets becoming part of a P&L. I am yet to see that. However, it will become a line item in the budget when it will start pinching not to pay for it. So, yeah. So any expense, like you have cloud services, you pay for that. You have medical gases, you have electricity. Can you afford not to pay for it? You cannot. So as of now, that stage is yet to be reached. So that's one. And there are again three things which will make it more, I would say, a budget item. First of all, as of now, AI sits on the top of any equipment or any of the services which we have. The services are not built around AI. So that is a change in future, probably, that it will happen. It will become more mainstream. Second thing, I already spoke about a clear-cut ROI. So we are yet to see. There are many projects going on which are very attractive, even financially, from financial viability. So we are yet to see that. So that will probably happen. And the third thing is when leaders will start asking why things are not moving, is something which can be done through AI, or is there an AI tool? So we are yet to ask as leader, can we put a AI tool to, expedite this or expedite the process, I think. And to set threshold. So I would again pinpoint to, the operator, and very quickly I will narrate incidents. So we have a 3D, mammography machine, which is very expensive, from one of the medical companies. Now I came across something called 𝗃𝘃, which is an AI-based, breast scanner, which claims to have, better efficacy and much lower cost, and you can mass deploy it. Now I tried convincing my breast surgeon, but I was not able to do that. She said, no, I don't buy it. So again, that was my failure. If I'm not able to convince my operator, that is the threshold, convincing my operator.
Neeraj sir, I'd just like to know, since he's talked about the stakeholders being the clinician, we try to adopt them and to have them realize that AI needs to be adopted in your hospital. But then if they become the advocates towards it, the agonist basically, then how does it help you to adopt your AI into your hospitals and not just the users? So they are the drivers, I can say. Just maybe in a quick,
Yeah, yeah.
because I
See,
think I'm getting an intimation for that.
just one example, I'll close it. See, doctor generally don't resist AI. The
Yeah.
bad workflow resist AI. So if you tell them the pain, if you tell them this solution will save this much of time, your reporting time is taking too much time, start with that. And there is a culture in healthcare ecosystem, make this committee, project management committee for AI. It will not work. Please create champions. Please create champions. Peer pressure will change the entire system in the hospital. There is 10 meetings, a committee meeting, and one clinician champion. He will change the entire system. And then maybe you can say, once it is started doing, you save 40 minutes for the day. If you start saying these things, I think it will change the way work. You finish your OPD 20 minutes prior. I think everything, your HIMS and everything is linked. Like I'm proudly saying, Medicover is the only hospital in this country which is 100% paperless. Our staff nurses have iPads and tablets. They don't have a medical records. We don't have a culture of medical records. We don't have medical records file. So everybody is having these tablets. Doctors generally e-prescription. So there is no prescription sheet. And this we started 1 year back. And now every OPD, every IPD, there is no paper at all. So I think if you create these kind of atmosphere into the hospital, that will change the way they work.
Thank you, sir. Thank you so much. I'll just move ahead further with Dr. Colonel Verma. Just to understand, now we look forward AI to enter into the clinical care pathways, the outcomes to measure onto it. Now, finally, it is based on some kind of an algorithm, some data, and all those things. What if something goes wrong with the patient, and finally that is a risk find, which I assign to it, that there will be a risk, and finally who is accountable is the medical director of that hospital first to understand what is it that has gone wrong, and the clinicians also disagree with the algorithm of that AI. No, this is not the way it has to happen, this is what not to be done. So what is it like, how do you learn to tackle that thing?
AI, that shifting is needed, AI being the technology tool to a clinical risk. And it comes with the responsibility when we involve doctors. So there are 3-4 stakeholders involved. Number one is the hospital, obviously. Hospital will introduce some system into the environment, and they will ask the users to use it. So hospital has to be accountable and responsible for certain things, selection of the good product, specifications, authenticity, and the verification, the technology justification, and all sort of the governance issues related with this technology adoption. Doctors will obviously be responsible or accountable for their clinical risk management, because they are using AI to assist them. This comes to empower them, so they should not outsource their decision making. Again, this is to empower doctors, so power comes with greater responsibility. The third thing, the stakeholder is the inventor or the introducer, the technology partner who will introduce this. So obviously he is also responsible for all these things. The bottom line is, see, we will be evolving, we will be adopting more and more cutting edge technologies, but in healthcare, the human touch, the empathy, the compassion, they are sacrosanct. They cannot be replaced. And when we empower the cognitive or the natural intelligence by the artificial intelligence, I think onus lies on us. So I always conclude with one quote, that is, integrity means honesty. So integrity without knowledge is weak and useless. Integrity without knowledge is weak and useless, but knowledge without integrity is dangerous and dreadful. So I think the onus lies on all of us to adopt the good technology for the better patient outcome, and the empathy and compassion are the cornerstone of the healthcare industry, and we believe We trust our doctors. We believe the management, and we at Lilavati, we have empowered the doctors to
Right.
practice and align with the motto of more than healthcare, it's human care.
Thanks, Dr. Colonel. Just quick question going again to Mr. Anoop Arora. So, a lot of, allies from there, we expect a lot of things to happen. Once that AI tool comes with there, it needs to integrate with the EMR and give the insights, real-time reports to be given and generated. So how far you feel that in India, the diagnostic setups, maybe rural, maybe urban, whichever way, are really at what level now, and what is it that is an impediment factor over there, that are we able to expect that thing to happen when the AI comes, or we feel still there is a long time to go?
I think I should quickly reframe it also. Getting a report to the patient on time, making your smart report, this is all is doing since last couple of years or maybe beyond that also. The only challenge that we are facing currently is interportability. Like until we are educate enough, until there is a challenge of acceptance among the hospitals and the diagnostics that they can interport their data, they can exchange their data among the system, then the actual worth of AI will get. The only challenge is not on technology part. Trust me, in India we are talking about HL7, the world is moving towards FHIR compliance. We are the first company who are FHIR compliant in our HIS and LIS. But the problem is not FHIR. Making an FHIR compliant company or HL7 is very important. But to convince to the Indian healthcare service provider, the hospitals, their owners, their members, even the diagnostic centers, to exchange your data open-heartedly is the challenge. The day our all service providers, healthcare service providers, accept this fact that sharing and caring means the more we share data across, that is more benefited to the patient. Trust me, I would conclude it in a way, AI in healthcare in India, AI is not we have an intent. We have an intent, but we are fail in execution. So this is how, if we can do that.
Quick questions to all the panelists with one line answer only I want from you all. Absolute, so that we are time frame bound. So when we have some AI proposal discussion going in some kind of a boardroom, the executive is sitting with the proposal, what is that one thing in the conversation he should push forward to you to make it clear or convince to get a yes from the board?
Yeah, so what is the intended outcome in the clinical terms?
What is the problem which will be solved by this? I think that's it.
1 year lead time. Have patience.
Are we ready to give the input from our legacy system?
Right. So I think that answers all the questions. I'd like to wrap up this whole panel discussion by understanding that the AI is not now any kind of just an healthcare initiative, what I look forward it is. It is itself is a strategy. That means we need to look forward what is the implementation process, what is the RCM, return on investment is coming or no, what are the tools going to benefit to us, how the metrics is what something needs to be defined, the KPI is what we can talk about, quality objectives or some kind of objective to measure it around, to understand the scalability of it. How are we ready for the AI, maybe in various sectors of the hospitals? That is what we want to understand that. Over here, we got the views from all the panelists to understand various insights from the clinician's perspective, the leadership perspective, from the investor perspective. What are we going to look at? Maybe the cost reduction factor. Are we enhancing the revenue into it? Are we engaging the patients? Are we having a better accuracy and the patient outcomes over there? This is what's going to be expected from the AI implementation. And yes, I will not say it's too far way to go, but yes, as the technology progresses, evolves further, faster and easier, we'll have the best thing which I always tell everyone is, please have the center focus to the patient. The patient is the person who's going to benefit from everything. So ensure that everything revolves around the patient. That is, patient eccentricity is absolutely important. Whenever any kind of a technology is going to give you, it should not just raise the cost to your technology and finally the burden goes to the patients. So that part I would certainly like to put it as a bottom line over here when we talk about the ROI over here. The patient has to benefit but not burden with the cost. Thank you so much. I think if you want to take a questions, please see that. We see some hand raised over here.
So I'll introduce myself. I'm a surgeon. I had been administrator. Now I teach AI in medicine also. And my whole thing will be from the regulatory and other aspects. So one, the topic is on the investment. So understand how the landscape in the AI in medicine is changing. So now after that October 2025 CDSO, so when you are using AI tools in your hospital, see to it that they are CDSO certified. Number one. Number two, the classes of the AI devices. So low risk is class 1, medium risk is class 2, high risk is class 3, where patient may have serious injury or even a death because of the AI output. When you are implementing, now what are the 4 ways we use AI in the hospital? One is for your administrative work. Number 2, one is your for care coordination. Number 3 is for clinical care coordination. And number 4 is basically patient facing, where patient also can use technology to their advantage. Because service industry, it is becoming a service industry. So these are the 4 ways out. So whatever you are using, basically if you are using a higher risk AI tool, so accountability is not only on the vendor or this or that, it is the joint accountability. Clinical, now I will come down to the high clinical grade AI apps. So in the, what happens is these equipment, over a time there is a performance drift. And for that, the clinical governance oversight. So that is the administrator's job, like in how to put the clinical governance in place. Because tomorrow a serious injury or death occur, then the hospital will face one, medical legal risk, number 2, regulatory and other thing. Number 3, from the IT vendor point of view, he has to be also accountable. So EU or USA, so they use, so when you are choosing a vendor, see to it that particular device is certified by the regulator. Number 2, it has ISO 14971 certification, because that is a hazard risk register you have to manage in the hospital, jointly by the hospital also and the vendor. And then IEC 62304. So in case there is some deviation occurs in that particular thing, basically he will improve that particular service. And number 4, when to stop it if there is some serious harm occurs to the patients basically. So here basically when the question is whom to put, decision is always taken by the board, but that hospital administrator and the other team, when they are working, they should know how to choose and what to look for when they are choosing that particular AI device. And number 2, when that clinician, they are or not, they will only accept a AI app if it has a clinical explainability in their workflows. So that is more important that they need to understand. Thank you.
Sorry, can we take one final question, please? We're running pretty... I'm sorry, I'll have to keep the questions a little for the conversation post show, but I'll just take one last question from the gentleman here.
Thank you.
Sorry, I need to
I'll make this very
time.
quick. My name is 𝗃𝗃𝗀𝗃. I'm a founder of a company called InfraTwin AI. We build digital twins for hospital infrastructure. My question to the panel is, because the topic is AI that justifies the investment, apart from moving from AMR and HIMS AI tools and SaaS, we don't see in India, globally, there's a precedent that digital twins are giving massive ROI returns across hospitals and other infrastructure. But in India, haven't seen digital twins being spoken of in the sector. Is there a conversation that is happening within the CXO level and all of this is being worked upon?
Very good question. I'll take it up.
Thank you.
The core is the AI tools in the clinical care pathway or in the patient care management. So whatever you said, EMR, HR, or in support system, that will come into play in any industry. But when we talk about the healthcare industry, what AI tools are being developed or being adopted into patient care management. So here 2-3 things. We have recently done AI analytics based or the sensor-enabled patient data capturing. I don't want to put the name of the brand, but it is something like a sensor has been placed below the mattress, and it will pick up your SpO2, HR, ECG, and blood pressure. Smart device, smart mattress. It will pick all the data, and there is a BCG, ballistocardiography. The technology name is ballistocardiography. I'm from the armed forces, so I can tell about this. This is something like motion-based sensor detection. It will get translated into the vital parameters, and this will be relayed to the cloud, and cloud will capture it, analyze it, and it will send back to you the actionable leads, so that your crashing in the ward, that means the code blue, the EWS calls, they are taken care of. This system is so sound that you are like alarmed well in advance, and the team can go and respond. So that is one system. Second, I mentioned about the hygiene and the cleanliness. Let's say when a patient is discharged, the other one is about to come in. In hotel, we have a beautiful system, and they tag it. This has been hygiene, like this, sterilized for your consumption or your use. We don't have such facility in the hospitals, but now it is getting into that. We should give this type of feel to the newcomer or new patient also. Coming to the robotics and the genetics, that is also being done, especially the genome sequencing, where we can predict the diseases well in advance. That is the health genometer, some sort of thing, or is a health snapshot, because the Gen Z or the new generation, which are very much aware of what is happening, 1 kilometer away. So this type of technology, where you can have a predictive analysis and a risk mapping of your lifestyle diseases, you can adopt them. Gene editing will be the next step, but there are certain ethical issues involved in this. So we are taking baby steps, but those will be evolved, and I think the future is very, very bright.
So your question was mainly, I believe, was based on the return of investment outside compared to the Indian scenario. Am I right?
I think that's a note for a healthy conversation. We should park that for the networking session, which will begin at 4 p.m. And I'd request you to wrap up. And we'd really want to thank each of our moderators for this entire beautiful segment. Can we have a huge round of applause?